he makes his grand entrance. And so we may continue. And thank you for coming. I am happily surprised at the good turnout in the middle of a three. I told him we should have 3 o'clock all the time and not 6 o'clock. Anyway, I am Stuart Rabinowitz. I have the honor of serving as chair of this board, and I'm happy to welcome you all here today. I need to take the roll call to make sure that we have our minimum for a quorum. So starting to my right, why don't you just...
Rory Landsman, and I'm here.
Okay. Jason? Who's here?
I think so.
Even though we had surgery last week, he's so committed, he's here. Thank you.
Lisa Warren here.
Yo, you're not a quorum.
Amy Florence present. Lisa Newland present.
Aha, I see we're all present, and therefore we have a quorum, and we could begin. Let me start by asking for a motion to approve the minutes of the last meeting, which was August 13th, 2025, which is attached to the board members' materials. Do I hear a motion? Mr. Abeloff moved. Is there a second? Second by Dean M. Can't pronounce that last name yet. And all in favor? Any opposed? Okay, unanimously passed. And so let's begin with a presentation from our interim president and chief executive officer, Richard Becker, Dr. Richard Becker.
Good afternoon, everyone. I'm on. Good. Thank you. Welcome, and thank you, Chairman Rabinowitz and the board. We want to walk through a brief presentation just to update you on where we are. A lot of progress is being made, a lot of hard work. Not only do I want to first thank the board for its leadership, which is essential in this situation, but I really want to thank the management team and the staff. The staff continues to be incredibly supportive, embracing the change that we're bringing, eager for it, and just helping us move the organization forward in some really, really positive ways. So, we're excited. The change is palpable. The direction is a positive one. Overall, a lot of optimism at every level that we encounter, and we're excited about that. So let me show you where we are. We have some positives just to prepare you, some things that still need focus and work, obviously, a lot of things. But again, we're really developing very solid plans around all of this. Some of this is an extension of what we talked about at last month's meeting, and we continue to build on the story that we're creating here, which is a positive one. As I've mentioned, we stabilized the management team. We're developing that even a little more. Completed some interim recruitments. I'll show you the reconstructed table of organization that really improves our ability to manage with efficiency and effectiveness. We're making amazing clinical progress, terrific support from our nursing team, our physicians, and our staff, really improving just general patient throughput and delivery of care, but with a real focus on perioperative services, ambulatory care, and inpatient care delivery, with really a rational approach to staffing that we'll talk about in a minute that's having a very positive impact. Making big progress on operations at a frontline level. We're developing dashboards with key performance indicators that we expect to have in place at the end of next month that we'll use to have a data-driven approach to management. Right now, doing the best we can with the data we have, but having regular streams of data to help us manage in an objective manner is going to be very helpful to achieving our goals across the organization. We still have significant financial concerns. That's not a mystery to anyone, driven by poor revenue cycle and poor expense management, but we are initiating a formal budget process that's going to be very different from budget process of recent years, that is really informed by discussions with each department. We'll talk about that a little bit more, and coming up with conservative yet realistic budgets that we expect um, are achievable. We're improving our financing, our financial processes, and our contracting processes. We've got detailed work and discussion with New York State, DOH, and the governor's office about financial support for both operations and capital. Those are ongoing, and once we have kind of final results, obviously we'll be informing everyone of that. But that is a very detailed and important process that is going very well from our perspective. And then strategic planning, as the chairman, may speak more to. We've initiated a strategic planning process that will really envision and capture the future and the transformation for NUMAC. We're excited about this. There's a great deal of optimism about ensuring that this hospital provides the set of services, and medical center really provides a set of services that are needed by the community and that are also sustainable. So more about that at another time. This is, and sorry for the busy diagram, I don't expect you to read everything on it, but this is our interim table of organization. It's been reorganized for a more efficient approach. One of the changes you'll notice is that we've consolidated the interim chief medical officer into the interim chief clinical officer, which is Dr. El Shanawani. What we found was that Dr. Barrios was very generous with her time in volunteering to be interim CMO, but where we really needed her was in the emergency room because there's a lot going on there and a lot to manage. So we really appreciate her time there, and she's refocused on the emergency room, where she remains chairman of that department. We're also recruiting for a chief compliance officer, as well as some additional attorneys to help our new chief legal officer work through the many legal issues, contracting issues, and so on that are here. So that's kind of where we are. But all the other positions that we've been recruiting for, all the other positions have been filled, and we're excited about that. The current financial position, I think the headline has not changed. It's precarious, but we do have a pathway forward. We're working hard to show early results. I'm very excited about the work in finance that's happening on the revenue side. Our managed care and revenue cycle leadership are doing incredible work to essentially recapture additional money for the same work that we've been doing all along, which is great news. If you can get paid more for what you're doing, then why not? And we deserve it, and we're going to go get that. There's an active focus on renegotiating our managed care payer contracts. That helps everyone, and also some significant revenue cycle improvements, both short-term and long-term, that are going to make a big difference over time. We're very focused on operations, on expense management, and just becoming more efficient with how we staff and how we work. Our workflows, our work processes are all under scrutiny, and we're looking at how underneath that org chart I just showed you are dozens of other org charts for each department, and we're looking carefully at those to make sure that we're organized best to deliver efficient and effective services, and that's underway, and that will make a big difference. Our turnaround plan, implementation, and success, as I mentioned, will require significant investment from the state, both for operating subsidies as well as for capital. We're working on accelerating the $50 million that was granted to us over 5 years for capital investment, and hoping to capture that much more sooner or much more quickly, and we are doing that. You can see that the operating results are on a trajectory with where we said they would be. And again, we're making changes. I think that the loss will be around what we said it would be this year. At the end of the year, we expect a loss, just to kind of just to say it, in 2026, we expect to require additional operating subsidy for calendar 26 as well. And that should not come as a surprise to anybody. But our hope is that it will be less and we'll still be more efficient and working well. This describes our budget timeline. We've started already. We've got feedback from the departments. We're going to, with Rich Miller, our CFO, and his team, going to be sitting with each department and going through what we call departmental budget interviews, where there's a proposal from the department and then there's a back and forth exchange for how that looks. And then we'll complete a budget that's a rational budget and an achievable budget that we believe will position us in a better way financially. That budget will then be presented to this board for its review and approval, and at that time it becomes something that we can work from for the next year. We expect to have that at the December meeting. A lot of operational focus and improvement led by our Chief Operating Officer. We've got improving operations at a frontline level, including clarity on individual and team objectives, and in many cases, this is not what existed before we arrived. We have data-based dashboards that are coming, as I mentioned, and position control, of being able to envision all the way down to the individual level what our positions are, how they're funded, and what they do in each department to monitor and review when additional staff is needed or not needed is something that we're getting better at doing and will become very good at doing. That will not only have an impact on finances, but it will have an impact on how we deliver service, which is so important. Our departmental effectiveness is being evaluated and analyzed. We are looking at how our departments are structured and whether or not we need to reorganize that. In some cases, yes. In other cases, no. I mentioned capital budget, and we've got a list that comes to about $50 million or so of capital that we feel is important and is needed, and we're going to push that forward to the Department of Health and hopefully get positive feedback soon. I mentioned we have some focus projects in clinical care delivery, length of stay, ambulatory care transformation, and our perioperative process. We're also initiating similar processes in supply chain management and infection control, where we think we can apply some focus management processes to achieve some near-term results. I want to just take a minute and walk through with you our approach to some of these issues, because it's easy to stand here and say, hey, we're improving length of stay, but I think it's important for you all to understand what's involved behind this, because there is a lot, and I mean a lot of work and effort and thought that goes into this. And the good news is that we've got very positive results and we're on the way. The first part, and we're doing this in every focus project and in every area, so this is really just an example of the type of thinking and the type of work that we're doing. Our first pass at this is to assess our current state, and what we found was a lot of things that weren't happening that should be happening, and some of this is just because that's what happens over time if you're not focused on doing it a certain way that produces results, and it requires a great deal of diligence and effort of focus and leadership to make sure this is happening. So we weren't getting discharge planning, rounding was inconsistent and not standardized, we had ineffective clinical documentation, care coordinators were physically siloed and unable to access patients easily. The whole thing just didn't really come together. So it required what you see on your right, a lot of identification of key issues and actions, and we've affected all of these changes already. So the action steps were to standardize and accelerate patient flow in our discharge process. Again, discharge planning begins on admission, and that really wasn't happening as well as it should. We restructured floors and units to increase access to patients. I mean, think about that. We had case management like in the basement and, physicians on various floors, and even those physician services were on several floors. So the physical act of rounding and planning took that much more time and was that less coordinated. So what we've done is relocate everything so that it's geographically, a team is geographically all on the same floor, and all the resources are right there so that decisions can be made and discharge planning and even the day's care plan can be decided upon, decided upon, and then executed very quickly. And that helps, first and foremost, patients, but it also accelerates the time that they need to spend in the hospital, which is great. So we've rolled out interdisciplinary rounds. Those were happening occasionally. Now they happen all the time and consistently. We've hired clinical documentation integrity or CDI professionals, or we're hiring more. We're focused on CDI, which is how you ensure that you get paid what you need to get paid and that you're collecting everything that you do. But it starts with documentation and making sure that documentation gets translated into essentially billing language. And so getting that done properly is something that we're very focused on. And that means more reimbursement for the organization and for folks who work here, which is important. So all of these things, not to walk through every one in great detail, but the big headline is that we've reduced length of stay by a day, which is incredible in that short period of time. That just doesn't happen. And we've still got work to do. So we took it down from, I think, 8.2 days to about 7 or 7.1 days with what's called a case mix index of 1.3 or so. That's our Medicare case mix index, which is fairly low. And what that tells you is that the length of stay can be even lower. And so our target, and we believe this is very achievable, and hopefully in a relatively short time, is 5 days. So that just sets a framework. So we were at 8.2, we're at 7 or so, and we're headed on a journey to at least 5 days, if not better. And we know that we can get there. And that's going to, first of all, be a great story. It's great for patients because we want patients to be here as long as they need to be here, but not a minute or an hour longer than they need to be here. That's the best thing for patients and their families. It's also great for the hospital because we don't get paid more for keeping patients here longer than they need to be. So all it does is cost more money. And we don't want to have to spend more money if we don't have to. And so that's the journey that we're on. Just to show you, and hats off to our chief nursing officer who's done an amazing job with this and is out and about all the time. But you can just see the reduction, and I'm not going to walk through every one of these changes, but she's done amazing work, to address overtime and agency spend. You can see that we've saved about $400,000 in just 1 month of addressing overtime and agency. So that's, close to $5 million on an annual basis. And we're just getting started. Rivka tells me don't get my hopes up too much, and that 400 is pretty good. And that's right, but we also think that as we, address recruitment and retention issues and a lot of other issues, building a float pool, there's a lot of other issues that we're addressing that I believe will address some overtime and agency spend. You're always going to have some. That's just how it is in this environment in healthcare today. But we want to really manage that expense very carefully. A. Holly Patterson, our long-term care facility, has many short-term and long-term challenges and priorities. We have had some initial success in hiring to fill some clinical, operational, and management gaps that are important to advancing quality over there. We continue to recruit in specific areas, physiatry, wound care, pain management, and some hospice services. We've got a capital list. We're going to try and put an electronic health record over there, which is a big step forward and will really make a difference in, just not only how we manage, but also how we get reimbursed and just how effective we can be. And then how a Holly can talk to the main hospital and so on. And just to reiterate, and the board and I and the management team talk about this all the time, A. Holly is absolutely part of our strategic planning process, and we're talking about what that looks like and how that goes forward. It's just being initiated, but for anyone who has concerns, Holly is absolutely on the radar, and that's important to say. So, just to summarize quickly, and then I'll turn it back over. We continue on the journey of stabilizing our cash position. I mentioned we're working closely with the Bureau of Financially Distressed Hospitals through what's called their VAPAP process. It's a very detailed and tedious process that we're working through, and we're pretty far along in that and expect to gain some significant financial support for operations very soon. I mentioned new management and continuity of service. I think we're working with the individual clinical leadership to identify what their needs are and figure out how to maximize what we have and then fill in gaps where we don't have that. We want people who are really engaged and very strong leaders, and we're working hard to accomplish that in a relatively short time period. Again, part of the reason we have dashboards is that it's a very clear way to communicate what the objectives are at every level of the organization. So wherever you work, we want you to know what your department's objectives are, and we want you to align with accomplishing them. And everybody should and will be able to understand their role in accomplishing a very clear set of objectives. Whether you're in the clinical areas, the operational areas, or the financial areas, it doesn't matter. Everyone's going to have clear objectives that they work towards. We're reviewing, and we've overwhelmed, Dan, our new chief legal officer, we've overwhelmed Dan with like a lot of contracts to review, but there's a lot of work to be done. There are many contracts that were either expired or not good contract terms for the organization, and we're doing everything we can to advance that and move it forward so that we have contracts that are favorable and align with our objectives and are at a fair market value. I mentioned capital needs, and that should go forward soon. I talked about focus projects and revenue cycle improvements in our budget. So I think we've covered all of that. You'll see this slide over and over again. This is what our focus is, and we're just unwavering in that. I think everyone, hopefully feels that. We want to preserve the mission of providing high-quality care to vulnerable patients. That's the sole focus of the board and management. We've got significant issues across the board that we believe are getting the immediate attention that was absolutely needed. And look, we're redeveloping NUMIC in a manner that truly ensures the delivery of high quality and sustainable services to meet the community's needs. Like our objectives, simply stated, better access, better experience, better outcomes. Like I said, you're going to see that mantra time and again, and it's one that I think we can all get behind. So thank you very much for your attention. I'll turn it back over to the chairman.
Thank you, Richard. I'm going to give a few people a shock by moving my remarks out of order because there's more people here than I thought, and maybe you have a question or you don't have a question. I want to address to my remarks, which were on the agenda at a later time, but before we go into executive session, I want to bring you up to date on the search for a permanent CEO, which is well underway and, believe it or not, almost complete. We retained Korn Ferry, which is a premier search firm, and contrary to prior statements made by prior administrations, we are very happy and very excited about the responses in terms of number and quality and experience of people who want to be our CEO. As I said before, unfortunately, that does not include Dr. Becker. I tried. But there are some really strong people with experience, with safety nets, and a record of success who want to be the CEO of this hospital, which is interesting because they said last time there were no candidates, so they had to appoint an internal candidate, but we have plenty of good candidates. And there were more than 20 applications that were looked at that passed the first level of scrutiny by Korn Ferry. Then they were reduced down to 8 or 9. I can't remember the exact number. And the search committee, which consists of members of the board of directors, but non-voting members, including union representatives and representatives of the nursing staff and of the medical staff and Dr. Becker. We interviewed these candidates thoroughly. It's amazing how tiring a whole series of Zoom interviews are. Really, I needed a nap halfway through. But they were excellent candidates, and just today we have decided to bring back 2 finalists for further interviews, presentations on their view of their first 30, 60, 90, 365 days if they were to be the CEO, and of course dinner to see if they drink too much. No, that's no way. Dinner with the board. I know you want their names. I can't give it to you. Each of them is gainfully employed at the moment in very good positions, paying more than we would pay them. And we have, in order to get the best candidates, we have promised confidentiality until the choice is made. But we will have the identity of a new CEO by our next board meeting, which is early December 2nd or something, probably before that. So the other thing I wanted to bring up to you is that I remind you that we are statutorily bound to give a report to the governor on the future of NUMAC by December 1, 2026. And when you think about it, that is not a long time to come up with a vision of NUMAC and changes in NUMAC which would be acceptable. And when I say which would be acceptable, we have 2 goals in mind. One, the board is determined, and I say this only because I just got a question from Cranes again. Our plans, there will not be a closing of NUMAC. There will be NUMAC at the end of the plan. And it will be a safety net hospital which serves the needs of those who need us most, which are those who are Medicaid or not insured of Nassau County, and view us as their hospital. And we want to, however we reform or changes we make, we need to provide the essential medical services those patients need and in those communities. And that is the number one given of any plan. On the other hand, we also have to become more fiscally stable. You cannot expect a government, and at this point it's really the state and not the county. I hope it's the county someday soon, but at this point it's really the state, to subsidize us at the tune of projected $250 million of losses every single year. Even if they wanted to do that, they just don't have the money. So we need to reduce our expenses and increase our revenues, hopefully increase our revenues, including monetizing some real estate which is not used at all currently, so that we get, nobody thinks we're going to, fill our coffers with surpluses, but so we get to the point at the end of our plan where we think either we're going to break even, that's very optimistic, or we're going to have a loss that's manageable, not $250 million a year, but $10 million a year. We're also going to look at building up our fundraising, our private fundraising. That's sort of why everybody loved me at Hofstra. I raised with help, I raised over $900 million of gifts for Hofstra. And I'm happy to say we're on the verge of closing without a lot of effort, $1,500,000 gift to NUMAC. And I think that there is a whole world out there of people in Nassau County with wealth who really care deeply about medical services for the most needy. And, you know, fundraising is not something that you can use, hopes of fundraising, not something you can use for permanent positions, but it could be used for new equipment, capital needs and so on. So we're going to do that. So we're well underway with beginning our planning. The other thing I can assure you is that the people in this room and the ones you represent will have input into that planning process. We're not going to whip out something on this November 30th, 2026 and say, by the way, here's the plan for your future. There are going to be meetings. There are going to be consultations. If we have to convince you of something, we'll try. If you have to convince us of something, we'll listen. It will be an open process. If we all have to convince legislators to support us and be our champions, I'll tell you who they are. I'll give you their cell phone numbers, and you will be appointed as our personal lobbyists with legislatures to get what we need done. And so we just begun that process. We had a great meeting this afternoon where we agreed on most things, disagreed on something, and then came to an agreement. And we're moving forward, but we're just in the initial stages of that. And that's my report. So I now want to, the main purpose of this, of all of our meetings, because I could always email you if somebody typed it for me, my report, is to get public comment or questions. So we always ask people to sign up. Nobody ever does. So you don't have to sign up. But if you have a question or a comment, please raise your hand. And if you're called upon, we'll give you a microphone and just identify yourself. If you want to argue, it's fine, or ask a question, but you do that with me. That's what I promised when I accepted the governor's office to offer to chair this. So, any comments or questions from the public, from the people in the amphitheater? I understand you can't call this an auditorium. It's an amphitheater. I'm used to auditoriums. There's a gentleman with a cap. I recognize him. I think he asked questions last time. Is that? Oh, okay. One of them would. Nobody on this board is paid a penny. I won't even, accept a reimbursement for an expense that's related, because the money is so needed for the cause, which is patient care. And I think you can't be CEO of this place unless you are passionate about being dedicated to what we stand for, and having a safety net hospital that provides service to the neediest. And this one person, makes a lot of money, but I think the person is local and is committed to the welfare of Long Island, and so is the other finalist. And that's why they're interested in this job. I think they're also interested in this job because of the job Richard has done in stabilizing a place which was in chaos. I mean, he came here. When I was appointed, there was no CEO, interim or otherwise, and there was no CFO. Everybody resigned. Computers were wiped. Files were, I'm not mentioning names, files were shredded. And they see what we've done and stabilized. stabilized in such a short period of time, and we are confident that patient care through that chaos did not suffer at all. And we also think that this opportunity of having the governor's backing and a board which is committed to maintaining our mission, but making changes to make sure we can be financially stable for the future is very attractive to the right kind of person. I mean, you go into a job, you know, in a stable place that doesn't need any changes, and you know, you may get paid more. It's a challenge. Every place is a challenge, but not like this one. And I think these two are committed to trying to do something new and are excited about it. That's why I think they're applying. Also, they made a lot of money already. You know, so did I. That's why I'm doing this for free. Yeah. Where are you?
I mean, the short answer, Maureen, is yes. You are correct. And I think that part of the budget discussion, obviously, there's a discussion about expense, but you can't plan expense unless you understand what you're talking about. You know, first and foremost on, you know, for example, case volume, right? If we're talking about an operating room, well, how many cases and what kind of cases are coming through? That drives the revenue, that drives staffing. So it's a multifaceted discussion, and that's the entire budget process. So to come into the budget process, which I know you're not, only thinking about expense, you know, that may have happened in the past. And in fact, we've seen here folks, you know, staffing to budget rather than staffing to census or acuity. And so that's what we're changing. And that's driven by a sound budget process, which Rich and his team are leading.
Half of the things that Richard has discovered as a former CEO of a different institution, this is much more complex, except for athletics, maybe. But I'm astonished at the lack of process that is like ABC of running an organization that existed. And that's going to change. And data. How could you not? How can you make decisions without it? Yeah, and we're talking about going to a new. Um, no. Okay. Okay. Yes. Yes. Um, here's where there may be some disagreement. I really don't think that we're in a position to compete with a lot of the wealthier hospitals. In some areas, in some areas of medical care on Long Island. To think that we can steal, neurosurgery doctors, surgeons, from NYU Langone or Northwell, or, that we have the infrastructure for brain surgery here. I think maybe someday, but not yet. And yet, there are, the standard of care here has to be as good as they would get anywhere. What the public perceives is a different issue. But I believe the standard of medical care here can be as good as any hospital around in the areas that we do service. And I think we need to get that mission out, that message out. And there are certain areas, I think, where we already have that reputation. I only know this from anecdotes, but I do know that, the go-to place if you are unfortunate enough to have significant burn injuries on Long Island is to our burn center. I know our emergency department is a level 1 trauma center, and while there are other level 1 trauma centers, the police department and the fire department, they're very happy that when their officers are somehow injured and need emergency treatment, come to a level 1 trauma center. But we can't do it across the board, because if you do that, you're gonna not succeed. But if we can do it in certain departments, and we have to get the message out there that patient care in general is excellent at the hospital, and our physicians are excellent and dedicated. And all you see out there are negative stories about NUMAC. Somebody's suing somebody, they're suing me, they're suing everybody, and there's chaos. We want to get stories out there about what's great about what's going on in NUMAC. And so we're in touch, and Dr. Becker has interviews with various media and press coverage to tell the good stories, the stories to speak to patients who are happy and what goes on. So I do think if you want to attract patients, you have to project the real image, which is you come here, you're going to get excellent care. And that is part of our responsibility. But I don't want you to think that we're going to, set ourselves up as, another Johns Hopkins. We just don't have, I'd love to, but, just like I wanted Hofstra to be in the Ivy League. But I think that there are limitations of finances that hold us back. Not of talent, but of finances.
Just to add, though, I think that a lot of that revolves around the strategic planning process that the chairman described as being initiated. And so in that strategic planning process, there can and should be and will be some thoughtfulness put into what types of programs could we go deep on. I think different than a major like AMC, like a Johns Hopkins or whatever, you're not going to do everything, which is the chairman's point, and I agree with that. There may be some things such as burns or other specialized areas that we say, there's a demand for that service locally, and so let's go deep on that. I think to your general question, the medical center here will not just be pursuing the most vulnerable. We are always going to be here for the most vulnerable, but we will also be and expect to be and must be highly attractive to people living in the area for a whole variety of general services, and not just primary care, but certainly surgical care and other types of specialties. So I think it remains to be seen. The first part is to address the reputational damage that's been done and get the good stories out there. Concomitant with that is ensuring that this moves from a 1-star CMS-rated hospital to a 5-star CMS-rated hospital. And on that journey, you build reputation and confidence, because people, for many types of care and probably for most types of care, want to go to the place that they can access easily. They'll get good care. It's good. It's a good patient experience, and they know it's high quality. If they can do that, they'll go to like the nearest place rather than driving into Manhattan or going to some other place that they don't need to. So
Nobody wants to go to Great Neck, definitely.
yeah. So look, it's a. Yeah, I feel like you were. No, I feel like you were. I feel like you were in one of our meetings. So, we were just talking about this because paying $9 for parking or $8 or $9 for parking, you know, is expensive for many people, and we want to respect that. And if we're going to put ourselves forward as a hospital that prides itself on access for the most vulnerable, we need to address that issue. We believe we're looking at a few solutions. The flip side is we don't want people to use us as a parking lot where you can just leave your car indefinitely. And so there are ways to do that. We'll probably come up with. We haven't baked this yet, but we'll come up with some kind of tiered, parking where your first 3 hours are, I don't know, make up a number, $1 or something, something low and affordable or free or correct. So we're looking. The point is that we're looking at solutions. We've identified that as a big issue, and we're addressing that.
Yes. Well, thank you for that. As Dr. Becker pointed out, we just very recently hired a in-house counsel, general counsel, and one of his small tasks is to go through 900 contracts, and he's begun that. And so, Daniel, did you take notes on her contract? Yeah, and we will certainly look at it. There's some horrible contracts around, just horrible, and you know this sounds bad. As bad as it is, there are some contracts that are just not explicable through rational thought. But yeah, yeah, yeah. Well, we have to have medical records and we have to store them. Yes, so you know, you want to be a hospital, that has to happen. So we will. we will again look at that. Yes. So a nurse is taking somebody. Is there a course on that in nursing school? I got it.
So again, there must be a lot of people in our meetings because we were talking about this issue as well. It's a big campus, and the distance between where some folks park and the entrance is significant, and especially for older or frail people. I'm not sure if this is what you're talking about, but we're looking at a way to provide some, type of shuttle transportation or some assistance in getting people to their vehicles. That's one thing. I know we probably need more wheelchairs and we probably need more assistance, more people to help, with that type of transport. So we're looking at that and don't have an answer yet, but it's on our list.
There are so many things to focus on, and we were just discussing yesterday that there's been a drop in the expected um, number of patients who come to our emergency room, and we were trying to find out what cause, if there was any cause for that. And it turns out that one of the causes is that um, if it's a police officer or the police or somebody comes in the police ambulance to us, the police officer, him or herself, has to take the patient out of the ambulance and help them get into the car. So the police officers aren't thrilled about doing that, and who knows if they're certainly not trained for that. But I think Dr. Beckham, when he heard about it, reassigned a security person who was guarding him and appointing them to the front of the hospital to help with something like that. So, yeah, we need to be made aware of that, and just feed it into it. So it doesn't have to be here. It could be, in the normal course of business to our COO, Trent is here, and or others, and let us know. And if we can fix it, we'll fix it. But let me just say one thing. I don't mean it as an excuse, but in a way it is. We just started. I was appointed June 2nd or 1st, and our first board meeting was June 10th. And I think Dr. Becker didn't actually get here until the 17th of June. So it's really, we've been here August, September, 2.5 months. And we made a lot of progress, but we haven't fixed everything yet. And, we'll get to it if you tell us what we need to do. And there's no way that we can imagine what to do. We need you to tell us what to do. Yes, sir. Yes. The turnover rate of employees hurts us, and it's a very complicated question as to why people are leaving. We understand that some of our salaries are way below commercial or other hospitals. That's not easy to solve because that increases expenditures at a time where we're already running a $250 million deficit in the future. But maybe, if part of the problem, we'll deal with, if part of the problem is that people don't think the administration cares about them, we're going to do everything we can to change that. We care about them. We care about our staff and our all of our staff. And we're open to suggestions. We can't do everything because we, like everybody else, is limited by funding. But we want to hear the problems. We want to sit down and work them out. And we're going to succeed at this. I mean, we all came to this board with a pretty decent track record of career success. Otherwise, the governor would have appointed us. And none of us intend to leave this board with the hospital not getting significantly better in every way. And, that's our goal, and we'll try our best. Okay, now we have to go into the horrible executive session. And we'll be back after executive session if you want to come. Thank you. Oh, is there a motion to go into executive session? Second, unanimous. To return to open session, I'm returning. Do I need another vote? No. Okay. So there was, we were not having a party upstairs. We were discussing very serious questions that took a long time. And for anybody who is anxiously awaiting our return, thank you. But I'm sorry we took so long, but it was necessary. On the other hand, we did not take any actions in executive session. We did not vote any actions which weren't privileged or confidential, and so no actions were taken that need to be publicly announced. Now, I am going to go out of order again a little bit because, number one, you notice Dr. Becker's chair is empty. He has not been fired or quit. He had to catch a plane, and since he can't vote anyway, we let him go. And Mr. Abeloff, who came from a rehabilitation bed, we want to get him out of here as quickly as possible so he could rest up. And we will still have a quorum of 6 members of the board, so when we do take a vote, we'll still have a quorum. But we're going to move up some of the matters before we get into the 2026 budget presentation made by Rich Miller. So let me turn it over to one of our great outside lawyers from Manat, Doug.
Thank you, Mr. Chairman. The first motion you will take up is the motion to approve the bylaw revisions. You recall we gave an update on these at the last meeting. It requires 2 meetings. They largely are to conform to recent changes in the law regarding board size, quorum requirements, etc. So I think the chair should entertain a motion on it.
We saw these, but it requires two meetings to approve. A second? Dean, you make more seconds than anybody. It's great. Thank you. All in favor? Aye. Opposed? Passed. Doug, next.
Thank you, Mr. Chairman. The second one is to appoint Dan Lindenberg as the Chief Legal Officer. He will also serve as the Corporate Secretary. Both are positions in the bylaws.
Dan, wave your hand. Yes, Dan. He's already swamped and doing a wonderful job. Any discussion about appointing Dan, who already is at work? No. All in favor of Dan's appointment? Okay. Dean moves it, and Amy seconds the motion to approve the appointment. All in favor? Aye. Opposed? None.
The next motion is Resolution 187-2025, and this is a motion to authorize Dan Lindenberg, now that he is Chief Legal Officer and Secretary, as a bank signatory to replace Kathy Jacopelli, who has been performing in that role in the absence of a Chief Legal Officer. You can take a motion.
Motion to approve. Okay. Dr. Newell. Second. Mr. Abelwolf. All those in favor? Aye. Opposed? Carried.
The next resolution is 188-2025, and this is to appoint 3 members of the board to the Finance Committee. That would be Mr. Abelov, Mr. Lansman, and Mr. Mihalcis.
I would note that I asked Mr. Lansman to chair that committee. Let the record reflect. Is there a motion to approve that? I read Robert's rules. I move. The chair can make a motion.
Second.
Good. All in favor? Aye. Opposed? Doug?
Great. The next resolution is 169-2025 to 179-2025. This is the resolution for approval of contracts. As the board does at every meeting, there are a number of contracts to be approved which have been included in your packets. We also note in the resolution those that don't need approval but need to go to the board for notification. So those are all included as well, and the chair can take a motion on that.
I would only add that these contracts have gone through a vetting process and are absolutely needed for the continued running of the hospital. Otherwise, we take more time in studying them. All in favor of the motion? Aye. Opposed? Carried.
And the last motion before we let Mr. Abelov go and hear Mr. Miller's report is the motion from the Medical and Professional Affairs Committee, the resolution to approve the credentialing packet. It's resolution 189-2025 to approve the credentials that have been forwarded by that committee.
Point of information, has Dr. Newell, who's chair of that committee, seen these?
No, this is directly from the credentialing committee. Dr. Newell
Okay.
is the chair of the board quality committee that I don't think has, right.
Say that again? No, I know, but it doesn't have to go through your committee. Next time, we'll discuss it next time. Obviously, there are going to be a few open issues and bumps in the road, but I would think that it should go through the board credentialing committee and then on your recommendation to us next time and forever thereafter. But meanwhile, we have these people deserve their credentials. I already went through how thorough they're checked out. And so is there a motion to approve the credentialing packet that was distributed prior to the meeting? All in favor? Jason, go rest up. Thank you, Doug. You're excellent at reading that. And now let me ask Richard Miller, who is doing a yo person's job as acting CFO, to present the budget projections for 2006 and the budget projections for 2007, 2008, 2009. Now, let me introduce this to say these are not budgets. These are projections, and we are not really saying that this is what will happen definitely. We haven't been here for enough time or have enough information to make these projections, and that the projections actually assume no improvements over 4 years, no additional aid from the governor, no nothing. That is not going to happen. So these are projections, especially for the years beyond 2006. So 2007, 2008, 2009, which we don't believe in. I mean, we think these will be much better for various reasons, and the losses will be less, hopefully, because that's our job. So why, you ask, are we submitting this to NIFA and the county and asking for the board's approval after Richard lays it out for us? Because the NIFA and the county and their lawyers and our lawyers insist that we make this estimate that we don't believe in. So I don't know. What we did was we just took the current year's budget, as Richard will describe, and sort of played it out as if nothing good was going to happen in between. And as I said, I didn't want to do it. I said there should be a waiver because, it doesn't count the improvements and we don't know yet. And everybody says the law says what it says. I spent my whole life teaching law and practicing law, and I know that the law often isn't applied the way it is written, but I didn't want to fight with NIFA or the county over this. Anyway, that's what's about to be presented to you. Richard?
Thank you. So a four-year projection of the NHCC operating results is required to produced each year and incorporated into the Nassau County budget, as NHCC is a component unit of the county. The information is also required by the Nassau Interim Finance Authority, NIFA, under Section 3669(2)C of the NIFA Act. The four-year projection that you see on the screen covering the years 2026 to 2029 is based on 2025 estimated operating results with trended assumptions for each category of revenue and expenses based on current estimates. These estimates may be subject to change due to numerous factors, including but not limited to demand for patient care services at NHCC, government payment rate trends and regulatory changes, and expense inflation. There has been no assumption in the four-year projection period of government aid, with the exception of $8 million in anticipated FEMA funds in 2026. Those are FEMA claims that have been filed already, and we expect payment in the first quarter of 2026. Nor has there been any assumption of the projected impact of management initiatives on operating results, as Mr. Rabinowitz just indicated. On both of these issues, management is actively engaged in an effort to close the gap in operating results to ensure the sustainability of NHCC. To put the four-year projected operating results into perspective, the 2024 audited operating results, which were reported at the prior board meeting, reflected a loss of approximately $149 million. The estimated operating loss for the current year, 2025, is projected at about $138 million. The forecasted operating loss for next year, 2026, as you can see on the screen, is approximately $185 million and reflects current operating trends, plus assumptions regarding changes to operating revenues and expenses in 2026. This forecast, very important, does not represent the 2026 operating budget, which will be presented to the board at the December meeting and will reflect revised assumptions, including the impact in 2026 of a series of management initiatives on both revenue and expenses. That concludes my comments. I believe we need a board motion to approve. So we're going to do that in a covering letter, in the transmittal, but I think it makes sense to put it as footnotes. We could do that, sure.
Right on the, because the cover letter could get separated.
Yes, and
Yeah.
if this is published, falls into media hands or some politician who wants to make hay out of it.
Exactly.
He does.
So as amended, that is, this with the footnotes, saying that it doesn't include more money from the government, it doesn't include management, improvements, all of which we think are forthcoming. All those in favor? Oh, make a motion, I'm sorry. Who moves?
I move it.
Second? All in favor? Dean's still holding the record, no second. Okay, is there any new business? I told Nancy, perfect. That's my wife. Any new business? No? Okay, can I hear a motion to adjourn? Second? All in favor? Good night, we'll see you at the next meeting.